Nice to virtually see you all. So let me just share my screen, and hopefully that's all up there and you can see that. So today's webinar is a little bit of a focus and perhaps revisiting some of the stuff you already know, but smoking cessation for the management of and prevention of respiratory disease. And a lot of this is taken from an article that I recently published in Addiction with a good colleague of mine and respiratory physician from Australia, Benjamin Kwan. Okay, oops, sorry. So first off, just to recap, we know that tobacco smoking shortens life expectancy, so people who smoke typically die around 10 years earlier than the non-smokers, maybe a little bit more in some cases. Overall, it's responsible for around about 2/3 of deaths in smokers. So people who smoke, 2/3 of them roughly will die of a smoking-related illness. And the major risk factors that smoking plays a role in, the diseases that smoking plays a role in, are cardiovascular disease, respiratory diseases, and cancer. And actually COPD is now starting to really move up the charts, I suppose, as a top cause of smoking-related illness.
Hayden, can you...
I just want to go back.
Sorry, Hayden, can you tell us exactly what COPD is and how it presents in someone who's got it?
Yeah, sure. In fact, I'll come on to that as we go through, but COPD is a chronic obstructive pulmonary disease. It's a chronic disease. It usually presents quite slowly. So a lot of people are, or a certain proportion of people are certainly undiagnosed because they just don't notice the symptoms until it gets quite severe. And then you really become short of breath. It's something we should probably do a lot more screening for, and can screen for it using spirometry. And some of the studies I'll mention have actually combined smoking cessation with spirometry tests. So when you find out that they've got early stage or mild COPD, smoking cessation is one of the best things you can do at that time point. So you actually capture people that are quite well motivated to quit. Mm. Now, in terms of major causes of death in Māori, and I just want to show you here these data that are part of the Y2575 report. And these are showing you the top 5 causes of death for Māori women and non-Māori women. And you can see among Māori women, number 1 is lung cancer, and number 3 is chronic obstructive pulmonary disease. Okay, both, well, actually all top 5 there are related to smoking, but there you go. Respiratory diseases appear twice in the top 5 causes of death. So in case you didn't realize the important work you do, this is why we do it. In Māori men, it's a little bit different. So ischemic heart disease is the number 1 there, but lung cancer is second on the list. And as I'll talk about, lung cancer, smoking is a major risk of lung cancer. In fact, the most important risk factor. So how does smoking cause harm? Just to refresh your knowledge here, there's a whole range of toxicants or chemicals in tobacco smoke. We often say around 7,500. Many of these, of course, are products of combustion, so they are formed when you burn the organic matter. And the thing with tobacco smoke is they've got some very fine particles in there that can be deposited really deep down in the airways. Now, there are some other factors too that can alter the toxicity of smoking. So, for example, how you smoke your cigarette. If you're taking large puff volumes, you're holding it down for longer, then that can increase the exposure to toxicants. Some of the blends and pepper preparations were certainly more toxic than others, and some of the burning conditions as well. So from the hotter the burn, then you're generating more chemicals. So it's not just a matter of, all cigarette smokes and the way that you smoke it is all the same. Things change over time. And that's possibly why too, we don't see a lot of health benefits with just cutting down. Because you get this compensatory smoking, you're changing the way that you smoke.
Hey, Hayden,
yes.
field quite a few questions from the stop smoking practitioners about clients who grow their own tobacco, just like on that risk factor with blends and stuff. What's your take on the harm of homegrown versus factory produced?
Well, there's not a whole lot of data on homegrown tobacco and harms because most people don't smoke it. And if you've ever tried to smoke homegrown tobacco, it's pretty harsh. So I think you've got to be pretty stick with it to get it down. So look, I don't know the relative harms of homegrown tobacco versus factory made, but I don't think you need to get into debate with clients. I just keep it really straightforward and say, look, whatever you're smoking, you're still inhaling toxicants to your lungs.
Yeah, okay, thanks.
So, okay, you're inhaling these chemicals or these toxins. What on earth does that all mean and how does it damage the respiratory system? Well, there are a number of different ways here, and I've listed this on this slide, but the toxins can cause breakages in the lining of the cells in the respiratory tract. So obviously, if you've got gaps, that's going to change what's absorbed. There's also inflammation that occurs with this as well. Smoking can change your microbial population as well. So they're the microbes that are usually resident in your respiratory tract, and many of them there serve a purpose, right? So they're sort of good bacteria, if you like. Smoking can change that, and with a change in that population, you can get more prone to other infections. All of our cells have a self-destruct mechanism. Now, this is called apoptosis, and this is a good thing, right? So if your cells go a little bit haywire, and this is what happens in cancer, of course, right? So you might get toxicants that cause DNA damage. The cell recognizes that, and instead of replicating a defective cell, it self-destructs. But with smoking can damage that process, so you don't get this auto self-destruct. So that's when you're more likely to get rogue cells starting to replicate, and that's very basically what cancer is. Smoking causes DNA damage, so you get changes in the DNA of cells. You get inflammation. The inflammation leads to airways obstruction. So with more of an inflammatory response, you can't get enough air into your lungs. It also causes destruction of some of the small alveoli tissue. And it can also lead to fibrosis. And fibrosis is stiffening of the tissue. So you've got a whole multitude of factors. If you can't move air in and out of your lungs because of inflammation, then you're going to feel short of breath. If your lungs are fibrosed and are stiff and they can't expand, then you're going to feel short of breath. So there's a number of different ways that smoking is causing the harm. Now, what about risk of smoking? Because it doesn't, if you've smoked 1 or 2 cigarettes in your life, of course you don't have, or are unlikely to have lung damage from this. So for lung disease across the board here, the strongest risk determinants are exposure. And exposure is related to how much you've smoked and how many years you've smoked for. And this is often measured in pack years. You might have seen especially respiratory doctors like to use this, and they'll say someone has a 20-year pack year history. Now, pack years is just a measure of exposure, and they calculate this by working out the average daily cigarette consumption multiplied by the number of years smoked divided by 20 being a pack of cigarettes. Okay, so if you have someone who smoked on average 15 cigarettes a day for 45 years, then you'd be said to have a 34 pack year history. Okay, so it looks at both the frequency of smoking and the time that you've smoked. That's all this measure is, but it's quite a good indicator of harm. So the higher your pack year history, the greater the harm or the greater the risk. Okay, so where in the respiratory tract does smoking cause harm? I'm just going to go right through. And I know you might not think of dental disorders or oral health disorders being caused by smoking, but periodontal disease is quite prevalent in smoking. So this is disease of the gums. You get inflammation, your teeth fall out. Some of you might have even come across people who, when they stopped smoking, their gums started bleeding. And this is quite common. This may be due to some of the effects of nicotine, where you've got less vasoconstriction, less constriction of your small blood vessels, and that may be why that happens. But yeah, stopping smoking is one of the best things for your oral health as well. If you're looking at cancers of the upper airways, then oropharyngeal cancer, and this is what I mean by oropharyngeal. So here you can see a cancer growing. It's sort of at the back of the throat, and you know, that grows. We're getting better at treatment of these sort of cancers, but often some of the operations are pretty severe in trying to get rid of cancers here, as you can imagine. People who smoke also have an increased risk of snoring and obstructive sleep apnea. Now, this may be due to upper airways inflammation. And so when you've got an inflamed upper airway, it's more likely to collapse when you're sleeping, especially if you're sleeping on your back. So one of the treatments of obstructive sleep apnea as well is to stop smoking. Stop smoking, lose weight, be more physically active. What about infections? Well, actually, people who smoke are more likely to get respiratory tract infections than those who don't. The little picture there has really nothing to do with smoking, but I kind of like the picture for you, Grant, maybe when you're out surfing. Pneumonia strikes like a man-eating shark. Anyway, so people who smoke are more likely to have infections of their respiratory tract, including bronchitis, tonsillitis, middle ear infection, that's otitis media. And these are both viral and bacterial. And we talked a little bit about COVID infection in one of our previous webinars. So that's a little bit unknown how we sit there. A particular type of pneumonia, pneumococcal pneumonia, that's the type of bacteria that causes that pneumonia, increased risk among smokers. And also people who smoke are more likely to have active tuberculosis infection as well. And there's some indication, although not strong, that smoking cessation may be a good treatment for people with TB. Right, lung cancer. Now, smoking is a huge risk factor for lung cancer. Now, I've just put some risks here just to give you an idea, and this is compared to never smokers. But if you're an ever smoker, so you're a current smoker or you used to smoke, you're over 5 times more likely to develop lung cancer than a never smoker. If you're a current smoker, you're around 8 times more likely to develop lung cancer. And ex-smokers, a little bit lower, about 4 times the risk that of never smokers, but it's still there. And that risk does take some time to go away, essentially. Now, on this little picture here, it just outlines the different types of lung cancer. You don't have to worry too much about that. But what I want to point out is that if you look at here, for example, squamous cell carcinoma, here's the proportion of non-smokers that get squamous cell carcinoma compared to people who smoke. Same with small cell carcinoma. There are a tiny, tiny fraction of non-smokers or never smokers that get this, but it's largely confined to people who smoke. As a class, adenocarcinoma, slightly more, of course, here among the non-smoking category. So it's not that it's only people who smoke that get lung cancer. That's not true. But as you can see here, it's predominantly people who smoke that get lung cancer. And secondhand smoke exposure also related to an increased risk of lung cancer. Remembering that this is mainly in those that are exposed to quite high levels of secondhand smoke, and that was particularly in bar workers, or the people that lived with someone that was a heavy smoker.
So Hayden, just going back to lung cancer from smoking being the #1 cause of death in Maori women.
Yeah.
What is the statistic? How many Maori women every year are dying from smoking-related lung cancer?
I don't recall off the top of my head, but I think that the key things to remember are that the rates of lung cancer among Maori compared to non-Maori are much greater, and the treatment outcomes are much worse. So it's not only that they're more likely to be diagnosed with lung cancer, they're also more likely to have a longer survival period. And when you map that all back, that fits very, very closely with the much higher rates of smoking among Maori women. And I think that, the more I look at all of these data, it just goes to show the importance of helping not only Maori women, but Maori in general to quit smoking. And we've really got to up our efforts in this. We're not really making any headway, or we haven't made any significant headway over the last few years, I don't think. And certainly in the area in which I work, the geographical area in which I work, we really need to up our efforts.
Okay.
Now, lung cancer, just a bit of historical data here, but this is showing you the association between cigarette smoked and lung cancer deaths. And just to point out, there's a lag time. Okay, so as cigarette consumption increased, as per capita cigarette consumption, you can see, some 20 years later or so, it was mirrored by an increase in lung cancer deaths. And then, of course, the cigarette consumption in the population decreases, and sometime later, the incidence of lung cancer also starts to decrease. So there's a lag time here. And here are the benefits of quitting smoking for reducing the risk of lung cancer obviously among a smoker. It does, however, take some time. So I guess, within 10 years of quitting smoking, you've halved the risk of lung cancer. Within 20 years, it's a quarter. But you can see, why the earlier you stop, the better. Because even out at 35 years of not smoking anymore, you've still got a fraction of a risk of lung cancer that's greater than a never smoker. So yep, it's absolutely important, but lung cancer is one of these things, and other cancers similarly take some time to reduce the risk. Now, I just wanted to mention lung cancer survival, and apologies for this here, but there's really poor long-term survival rates. So this is weeks from diagnosis. And the different colors indicate, the different colored lines indicate the different stages of lung cancer. Now, the good news, if there's some good news here, is that if you diagnose lung cancer early, so this is stage 1 lung cancer, then you're much more likely to survive for longer. And you can see here that around half of all people diagnosed with stage 1 lung cancer are living 260 weeks out. Okay, so what's that? It's about 5 years, isn't it? 5-year survival. So that's pretty good. But if you look at stage 4 lung cancer, a tiny fraction of them are surviving for that long, and most die within a year. So the earlier you catch lung cancer, the better. And treatments are improving for lung cancer. We are looking at lung cancer screening and early diagnosis. So therefore there's longer survival. And so in these people, smoking cessation is going to become really important, because we know that if you've got lung cancer and you're still smoking, you're going to have poorer treatment response. So that's the treatment response to the lung cancer treatments. There's increased risk of toxicity to the treatments that you're receiving. And then if you're still smoking, there's a chance that you're still going to have another type of lung cancer, or you'll get another recurrence of the same type of cancer. So as we get better in treatment, because a lot of people say, oh, I've got lung cancer now, what's the point? Well, the point is, as we've got better at treating and catching it earlier, the benefits of smoking cessation are becoming even more important. So we know smoking cessation is going to contribute to better prognosis and certainly an overall survival, but of course reduce your risk of dying early.
So what are some of the signs that would lead to you to assume that someone may have stage 1 lung cancer?
Yeah, it's really tricky. You know, a lot of the signs, then it might be a cough, and a lot of smokers have a cough and they just think, oh, it's just a cough, I've had that for ages. It's not until it gets to quite late when they may be starting to cough up a bit of blood that they think, oh, this isn't normal. But often by the time it gets to that stage with symptoms, it's too late.
Mm.
So there's some good work that's been done in fact, it's the next slide, that's been done in the UK. And certainly we're thinking about this, how we might roll this out too in New Zealand, but you can detect lung cancer early. And there's lung cancer risk scores. And so you can screen people who smoke or used to smoke. Those that reach a certain risk criteria, then you give them a CT scan. And the CT scan will be able to help diagnose cancer really early. So in this pilot of 2,500 ever smokers, so current or ex-smokers, they detected 46 cancers, and 8 out of 10 of all of them were early stage. So, you know, this, out of screening this many people, this sort of detection rate's pretty good, especially given that the treatment is getting better. And if you catch it early, it's really potentially curative. So, you know, there are things that we can do to reduce the risk of people of dying of lung cancer. And smoking cessation is a really important part of all of this as well. So, you know, if your DHBs are thinking about doing lung cancer screening, make sure you get in there, because that's going to be mainly in smokers that are going to be offered this, and we could help people stop smoking at the same time. Okay, COPD, chronic obstructive pulmonary disease, as I've already mentioned, that's one of the leading causes of early illness and death worldwide. Smoking is still the most important risk factor for COPD. And really what we're talking about here is destruction of the air sacs. So here are the alveoli in a healthy lung, and what you're seeing here in COPD, the walls are broken down, you're getting these big floppy alveolar sacs now. The airways can't be held open, so it loses its sponginess or, you know, springiness. And what you do is you get collapse of these small airways. So you can't exchange, you can't move air in and out of your airways, in and out of your lungs so easily. And often what you see in people that are really quite far down the track with COPD is they typically breathe at really high lung volume. So they have to breathe at the top of, you know, the top of their breath. They're trying to hold all of these airways open. And smoking is the major cause of COPD. Now, not everyone is susceptible to the effects of smoke and damage in this way. So it's not everyone, but it's difficult to know who's susceptible and who isn't. And what this graph is showing you is a decline in lung function. Don't worry too much about the measure over time. Now, this is from, you know, in your early 20s here, and showing decline of lung function. We all have a decline in our lung function over time. As we get older, we can't exchange air as well as we could when we were younger. But if you're a smoker who's susceptible to the effects of smoking, this is your decline in lung function. And when you hit a certain point, you can't really move about as much anymore. You may even not be able to walk to your letterbox. And then when you get down to a certain point, obviously it's not compatible with life. And so what you see here is, people who smoke a really rapid decline in their lung function. But what the good news is out of all of this is if you stop smoking, the decline in lung function returns to that of a non-smoker. So it doesn't repair the damage that's already happened, but it slows the progress. So here is someone stopping at the age of 45, and you can see that they're going to get an extra 10 years of life that they wouldn't have got if they carried on smoking. And even, if you're stopping later, you can certainly improve the quality of your life.
Okay, so Hayden, if with Maori lung cancer rates being what they are, do you think it would be helpful to show Maori smokers the number of lung cancer deaths in Maori and then that slide? This is the benefits of quitting, or do you think that would be detrimental?
I think it's always better to focus on the benefits of quitting. I think we'll see a growing number of people with chronic obstructive pulmonary disease as well. And look, if we can get into better screening earlier, this is where this sort of information can be really important. Because if you carry on smoking, you've got a fairly certain trajectory. You're not only going to be disabled, and you're not going to be able to do all the things you'd like to do, but you're going to die early. And we're talking at least 10 years early. But if you do stop, and it's never too late to stop, then you're going to have a better quality of life and you're going to extend your life as well. And what this slide was showing as well is, it's better if you stop smoking completely. So this is looking at over time, over 11 years, and the change in lung function in smokers that quit completely. You can see how, you still get some decline, but it's pretty flat compared to those that carried on smoking. But even those that had quit and then relapsed and quit and relapsed, they still had a better lung function 11 years on than those that carried on smoking completely. So, even when you've got people that are relapsing, encourage them to keep on going, because this is really, really important. And it's still the best treatment that we've got for chronic obstructive pulmonary disease. Nothing's changed, really. Stopping smoke. If you're a smoker, the best thing you can do is to quit. Now, asthma, the studies on the association between smoking and active smoking the evidence is a bit weaker. We know that smoking can exacerbate asthma, but we can't say that smoking causes asthma. Okay, so what we do know is that people who smoke compared to those that don't, who have asthma, are more likely to have, need more rescue medication. So their inhalers, their bronchodilators. They're more likely to have severe asthma symptoms, and overall, they just have poorer health. So the advice can still be the same here for people with asthma. It would be a good thing for you to stop smoking, because we know that it's going to help the management. What we're not so sure of is if smoking causes asthma. I think that's, just looking at the time, I think that's about it. But I think, just remember that smoking remains a major cause of respiratory conditions, especially in COPD and lung cancer. And remember, in Māori women, lung cancer is the #1 top cause of death, and COPD is #3, but I think we might see this increasing over time. Preventing people from smoking, from starting to smoke in the first place, of course, is important, but so is helping those who smoke to quit smoking. We can work closer with our respiratory colleagues. I think that's going to be absolutely critical as we see better treatments. Our screening becomes better. I think in terms of lung cancer, survival rates will improve, but getting in there and helping those with lung cancer to stop smoking is going to be even more important. I'm not saying that's going to be an easy job. I'm sure you can appreciate that if you've been diagnosed with lung cancer and you still haven't stopped smoking, then you're probably a fairly dependent smoker. So we're probably going to have to look at quite intensive or new ways of helping support people to quit smoking. I think that's it, Grant. That's the end of that.
Okay. Thank you very much, Hayden. That was great. So we can open the floor up to some questions. Don't feel shy. I'm sure if you've got a question, there'll be someone else on this webinar who would also like the answer. Yeah, go for it, Sarah.
Kia ora, Hayden. I've got a couple of questions. First one, I've seen some work out of the UK with starting varenicline alongside NRT for inpatient respiratory patients as a protocol. Do you know if anyone's doing that in New Zealand currently?
No, I don't know anyone that's doing that in New Zealand, and currently under the special authority that wouldn't be approved.
Okay, yeah, it was just you know, proven cost benefit analysis coming out of the UK there, so I was just beginning to wonder. But
yeah, I think that's you know, and I do know patients that, I don't know, have a stock of NRT left over somewhere else, and they say that it helps them quit smoking in addition to the varenicline. But as you know, under the current terms of the special authority, patients commit to not using one of the other products at the same time.
Yeah, I was thinking about that situation where they're using the NRT acutely while they're waiting for their varenicline to load, and then by the time they're leaving the ward, they're having follow-up support and they are varenicline only. You know, it's just that season moment when they're there.
Which makes perfect sense, of course.
Yeah. And then the other one, thoughts about vaping with COPD clients?
Well, I sort of take this on a case-by-case basis, and often people with COPD have tried everything. And so I think that if they haven't tried vaping and they're keen to give that a go, I'm very open to that. Again, given that sort of balance of risks and toxicant exposure, vaping's not perfect, but it's less harmful than smoking. And if it gets them off cigarettes, which is the major cause of their illness, then I think that's worth a go.
They might be near that intermittent quitter profile or somewhere in between that.
Yeah, I think that's probably right, Sarah, that if we follow them up long enough over time, that's probably where they'd sit. They'd not be as good as someone who quit with no exposure to anything in their lungs. But I think it will be much better than smoking still. So, we don't have time to wait round for those years and years of data. And I think, the priority is getting people off smoked tobacco and then assisting them getting off vaping when we can.
Sure. Thank you.
Okay, so we've got time for one last question, if anyone's got one.
Well, there's a question on the chat. Hayden, there's a question on the chat. It says, if you would know how radiation treatment for lung cancer would it affect a smoke ELISA reading?
I didn't see that on the chat. Radiation therapy won't affect a smoke ELISA reading, or at least not to my knowledge. The most likely thing to affect a smoke ELISA reading is smoking. So remember, people that have got smoking related illness, especially cancer, are a little bit embarrassed sometimes to even admit that they're still smoking. Because they know that this is a severe, serious smoking-related illness. To admit you're smoking takes a lot of guts. And I think we probably do need to be a little bit more, or get better at how we have these conversations with people that are diagnosed with cancer and say, look, we understand, we know that quitting smoking can be really difficult, but we're here to support you in doing whatever you can to get off the smokes.
Thank you.
Okay, well, thank you, everybody. We're due to start another webinar, so I'll have to park any more questions you have there. But thanks for attending. Thank you, Hayden, for a really informative presentation. And remember, that's been recorded. It'll be up on our website in a few days.
And Merry Christmas, everyone, and Happy New Year. I hope the New Year starts a lot smoother than this year's been. Yeah, I'm not too sad to see this year go, but I think there's going to be lots of work to do in the new year, especially given we'll be another year closer to 2025. So thanks again. Nice to see you all.
Have you got my postal address for my present?
Sure, Grant. Yep. Send that to me.
I'll send it. Okay, thanks everyone.
All right, thank you, Dick.